So thank you my 6 fellows for preparing the document. I'm talking about the difficult lateral meniscus. So what makes the lateral meniscus different? The anatomy, function, and also the way of the repair. So this is a lateral meniscus. You can see that lateral meniscus is more mobile, right? And that's a meniscal femoral ligament, the Humphrey wristbone. And also this, the sharing 70% of the joint load. There's a popliteal hiatus, okay? And there's a vessels, popliteal artery in the back. There's a peroneal nerve, okay, at the side. So the lateral meniscus is totally different from medial side. An additional role of the lateral meniscus is to prevent the rotational stability, to improve the stability of the rotation together with the ACL. Okay, if you have torn lateral meniscus fluid together with the ACL, you have severe pivot shift positive. So we cannot just poke it in wherever we like, okay, for the lateral side. So this is our study about the neurovascular safety in or inside lateral meniscus repair. So we found that the meniscus repair very close to the root, okay, using the anterolateral portal, okay, about 8 millimeters from the root. If you use all inside, it's really dangerous, okay. And this is another study also confirmed that if you repair the meniscus root, meniscus very close to 10 millimeters from the insertion is so risky. And also the common peroneal nerve also not safe if you try to repair the meniscus, especially you come from the opposite side. You're repairing the meniscus from medial side, you may injure the common peroneal nerve. Okay. So what about the popliteal tendon? So popliteal is a unique structure on the lateral side. This is the dynamic structure. So you may have irritation or loosening when the patient keep moving the knee. So the meniscus anchor may lose over time. Okay, we don't know about that. This is an article from France. Dr. Chernchujit, he have 251 lateral meniscus repair all inside using the fast fix into the popliteal tendon. He said there's no problem about the problem. There's no problem with his patients. So anyway, the long-term effect of the tying lateral meniscus to the popliteal are not known, right? So again, the lateral meniscus try to be different. The discoid meniscus is totally different. It's only available in the lateral side, right? In Asian population is 10 to 13%. Is more the incidence is more comparing to the western side. So what do they have in common? So the basic tear types are the same. Okay, longitudinal tear, radial tear, horizontal tear, bucket handle, flap tear is the same, and the way the rule of repair are also the same, right? So we prefer the outside in for the anterior part, we prefer the inside out for the body, right? And also all inside for the posterior part, okay? And this is the same, the concept of the repair, okay? So we just need to respect the anatomy and very careful, and you need to know where the risky structure when you're repairing the lateral meniscus. So for the lateral meniscus, you have no magic point like the medial side, right? You can open the joint and you can repair the meniscus fluid, radial tear, yeah, easier because you can increase the joint space. But for the lateral side, it's really tight, yeah. There's no magic point, same like the medial side. But when you bend the knee in figure 4, luckily the vessels and the peroneal nerve drop posteriorly in flexion. So you'll be safe when you repair the lateral meniscus because you need to bend the knee, right? You cannot repair the lateral meniscus in full extension. So, and also you need the strong fellow to open the joint for you, right? Until now, there's no magic point for the lateral side meniscus. Someone proposed releasing the popliteal or the LCL, but I never have that experience. So for the neurological structures, you have to be very careful, especially if you repair the meniscus from the anterolateral working portal, or you repairing the meniscus from the medial side close to the popliteus, because the peroneal nerve is just very close, just behind the popliteus tendon, right? So careful when you're repairing the meniscus to the popliteus. Like Sonali Cortez said, yeah, you may injure the peroneal nerve. So that's another study. They found that the distance from the meniscus to the vessels is about 9.5 millimeters. The safe zone is about 10 to 15 millimeter. So use the proper device for the lateral meniscus repair. Okay, I show you one patient. This patient had bucket handle tear of the lateral meniscus. Okay, so you see the popliteus is there. So for the lateral meniscus, even you have the tear size is not that long, the patient may have bucket handle like this patient. Okay, he have the bucket handle, it's not so bad, but the patient have bucket handle lock, even the tear is not too bad. Then you can use the new special device. This is from Smith Nephews. Okay, you can repair the meniscus all in one shot using the all inside. You can avoid injury to the popliteus using this we call the novo stitch. Okay, and then you repair the meniscus, preserving the mobilities of the meniscus. Okay, then you can repair another stitch. So I think this is really the ideal indication for using this novo stitch. The lateral meniscus tear close to the popliteus tendon, right? So I prefer using this novo stitch for the lateral meniscus repair. Okay, so you can see that I can preserve the mobilities of the lateral meniscus and preserve my popliteus tendon, right? And then I do another stitch for my posterior horn meniscus. Okay, so that is the lateral meniscus repair technique. That's different from the medial side. I have few cases. The radial tear, the lateral side, I think this is very difficult. This patient have 40, he's a 45 years old, motorcycle accident, ACL injury, together with the lateral meniscus tear. So this first radial tear is very good to repair. So the patient have the torn meniscus and this part is locked. I prefer to do my femoral tunnel first before doing the repair, because if you do the femoral tunnel first and then you do repair, your repair may be fail because you need to do deep bending when you do ACL reconstruction. So keep in mind, try to do the ACL tunnel, femoral tunnel first, okay, and then you come back for the meniscus repair. Okay, and the result should be good because this is fresh case. Okay, another patient, she also have this patient have torn medial root. Yeah, you see that torn medial root and lateral meniscus radial tear. Okay, like this. So you can use the mid lateral portal, same like the ACL. Okay, because sometimes it's very difficult to pass the instrument into the lateral side. So another way is to use a mid lateral portal using the suture hook, and then I can pass the suture. Okay, I prefer to do side to side repair. I will not repair my meniscus to the capsule. Okay, for the lateral side, I try not to do that. Okay, if the tear side is close to the popliteus. Okay, like that. And finally, you can get this side to side repair. So post-op, the patient doing well. I have a mid transpatellar tendon portal also because I need to do shuttle for the lateral side. So two portals sometimes not enough. You need mid lateral portal. You need the transpatellar tendon portal also to do the suture management. So anterior horn tab, lateral side also common. It's like the anterior lamb lesion of the meniscus. You can see that this patient have the anterior horn meniscus tear. It's same like lamb lesion, but this is in the anterior part of the lateral meniscus. I rarely see this in the medial meniscus. It's common in the lateral meniscus. It's torn at the meniscal capsular junction. Okay, I use the all inside repair using the mini first pass and then tie the knot. Okay, like that. Okay, so after knot tying, I prefer to put the knot in front of the cartilage like that. Okay, so it's look like lamb lesion, but this is the anterior lamb lesion of the lateral meniscus, right? So the patient doing well after surgery, and the anterior soft spot pain, chest pain at the anterior lateral soft spot, now it's getting better. So the bucket handle of the lateral side, this is like a patient have double anterior horn side. Just ACL injury also have the bucket handle of lateral meniscus. Okay, like these patients. Okay, so we do the bucket handle repair. Okay, same way. Yeah, I use this way you can use the Nova stitch or mini first pass to tie the knot. Okay, but sometimes you may stuck with the soft tissue like these patients. Yeah, I think the new way should be better, because if you use the same portal, you may have some soft tissue impingement like that. You need to retrieve the suture. Yeah, so finally you can solve the problem. Yeah, like that. Yeah, that is the all inside lateral meniscus repair. This case is quite interesting. Has the complex tear of the bucket handle lateral side. You see popliteus, but you cannot see the meniscus. The meniscus is stuck in the posterior part of the joint. You see that? It's this pressed to the back, very close to the vascular. So when I get in the joint, I cannot see the meniscus at all. Okay, I see the popliteus, but there's no meniscus on the lateral compartment, right? So I find that the meniscus is pressed to the back and stuck to the posterior capsule. Okay, like that. So this case is very difficult, and I try to use the inside out reduction repair, but it's impossible because the gap is too wide. Okay, you see that? It's very big gap. We cannot reduce that. So in this situation, you need to do the complete release of the meniscus first. See that? The another part of meniscus is stacked in the back. So what we have to do is we use a transseptal portal to release the meniscus, release the menisco-capsular junction, create the lamb lesion, okay, for the patients, like that. So after you create the lamb lesion, complete mobilizations, like that, then you can repair the meniscus again, right? Coming to the front. Yeah, now the meniscus is mobile, and finally we can repair this meniscus, right? Using the combined inside out, outside in, and all inside. Okay, like that. Yes, finally we can save his meniscus again. Yeah. So the posterior root of the lateral meniscus, like Roshan asking, so posterior root sometimes is look like nothing. You look like, because the meniscus try to heal, and you can see that the meniscus is floating like this. Okay, it's not obviously torn, and you can misdiagnose. Even the MRI from the radiologist may miss that diagnosis, because you cannot see the gap, because you have Blitzberg and Humphrey, you cannot see the gap. So this is a classification from Ahn. So I do my lateral meniscus root after I doing the femoral tunnel. Okay, after we mobilize the meniscus, I do femoral tunnel first, then followed by the meniscus root repair. You can do the transtibial. Okay, you try to catch. I will catch my meniscofemoral ligament, the Ritzberg ligament, and also the meniscus. So you need at least two. Okay, and after that we do the reconstruction of the ACL and tie to the post. This patient, she's a doctor. She has the unstable discoid meniscus lock. Okay, So you see that this is a big discoid meniscus and this press lock in the middle. So this patient first you need to decrease the size of the discoid first, otherwise you cannot reduce it. Okay, and sometimes if the Lisberg is very thick, sometimes you need to release the Lisberg ligament also, right? And then we repair her meniscus, okay, like that to the capsule. So after surgery, and now it's about 2 years, she's doing well and good motion. She can go back to jog again. She's very active in sports. Okay, so this is another patient. This patient have the unstable discoid meniscus, Risberg type, and also the meniscus is very unstable and snapping. Okay, so we restore the meniscotibial fixation using the suture transtibial fixation, and after
Recording in progress.
Fix the meniscus back to the bone is stable, okay, and the function is good. So in conclusion, on the lateral side, the anatomy is different, it's more risky. So respect the anatomy of the meniscus, careful the vessels, popliteus, common perineal nerve. You need the strong fellows to open the joint and use the proper instrument for lateral meniscus repair. Thank you.